again, introducing myself, Vikas Patel. I am a non-surgical orthopedic. I work out in Avon and Lorraine offices with the Cleveland Clinic. So excited to talk about some of the things that we run into every single day. Most common complaint that we get is generally related to arthritis. So we're going to talk about kind of some of the medications, and then we'll kind of go from there. So let's make sure the slides are coming through. So the game plan will be for first, I always like to kind of give a background and define arthritis, define what we're treating and what we're doing, and exactly that helps us to get the background information. That way we can figure out why are we treating with certain things and that sort of thing like that. And then we'll go through some of the different medication options that generally would be discussed with a primary care provider, an orthopedic, perhaps a rheumatologist. And then, as Kelly said, we will have a little bit of time for Q&A at the end there. So what is arthritis? Well, technically, arthritis is inflammation of the joint. So itis meaning inflammation, and arthur, Latin meaning joint. So the technical term of arthritis is inflammation of the joint. Uh, as we all know, it's a very common issue, affects 50 million adults and about 300,000 children. There's many different types, over 100 to be honest. The main focus of today will be for osteoarthritis. Um, and so again, arthritis is the loss of the cartilage. Cartilage is a smooth surface. So when arthritis kicks in, it's we're losing the cartilage, which is smooth and low friction, and we're actually kind of replacing it with a lot of times with bone, which is a more of a higher friction surface. So how I like to usually explain to patients is kind of like rust or potholes in the joint. So if I go back one slide, you can kind of see in the picture where we have a nice healthy joint. This would be, a lot of times when we're younger, when we're talking about osteoarthritis, where the cartilage is nice and smooth. And then as we do get a little bit older, you get a little bit more wear and tear in the cartilage. Sometimes it can be after an injury. A lot of times genetics plays a huge component in as well. You get these little potholes. And so the potholes is the wear down of the cartilage, and causing removing some of that smooth surface and causing some can be a cause of pain then. So osteoarthritis specifically. So like I said, it's more wear and tear. It is more degenerative. There is the primary osteoarthritis, which again is more wear and tear. There is post-traumatic osteoarthritis, which is from an injury, from a trauma, sometimes after a surgery, that sort of thing like that. So again, we're replacing the smooth cartilage with little potholes of bone, that sort of thing like that, decreasing joint space, and in turn causing discomfort. So common symptoms, and how do we come up with a diagnosis of osteoarthritis? So common symptoms would be joint pain, swelling, stiffness, decreased range of motion, and then diagnosis generally through physical exam, and then X-rays would be the main modality to diagnose osteoarthritis. Sometimes further imaging such as MRI and CAT scans can help in looking at a more detailed component, but most of the time X-rays will pick up osteoarthritis. So what causes the pain? There's some different thoughts in the pain generators. The number one cause is generally inflammation. And so that's going to be something part of the topic. Again, when we're talking about what causes the pain, well, what can we use to help with the pain? And like I said, one of the main pain generators would be inflammation. So inflammation is an aggravation of the joint, in this case in the joint, and that can lead to increasing your pain receptors and increasing and causing pain. There is the thought of the fact that the joint could be quote burned out, and inflammation is not the case anymore. And that's where we get more of the degeneration of the joint, the mechanical wear. And that's where sometimes when we have more of the end stage arthritis and we're kind of bone on bone, you might have heard that term before, and we're kind of rubbing up against each other. And that mechanical aspect is actually what's causing the pain and not so much the inflammation. So now that we have a little bit of a background of, what is arthritis, what are some causes of pain, now we can dive into what the main topic here and what are the modalities of treatment. So I broke it down into three different categories, and that would be topical medications, oral, and injections. So we'll talk about each one and kind of some different categories in each one of those. So the first one we'll talk about is topicals, your salves, your creams, all that involved. So there's two main categories within the topical group, and that is counter irritants and topical anti-inflammatory. So your counter irritants would be the things like Aspercreme, Bengay, Capsaicin, Biofreeze, Emu. There's a bunch of them out there. These are generally all over the counter. And the way that they work is actually decrease the irritation of the skin from the underlying arthritis or inflammation, and what have you. So it doesn't actually get to the root cause of the pain, which most of the time is inflammation, but it can be a helpful in helping calm down pain. A lot of times, we'll recommend using some of these to try to help massage into joints, and that can be a kind of a source of a pain reliever too. Excuse me. So advantages. So we'll go into kind of advantages and disadvantages of each of the categories. So advantages, again, very little effect on the rest of the body. You could localize by using the cream right to the spot where it hurts. So whether that's the knee, if it's a hand, if it's shoulder, any of those areas, you can rub it right in there, and like I said, very little amount gets into the rest of the body and have an effect. And the fact that it doesn't affect the rest of the body, there's very little interaction with other medications and other conditions. As you'll see, as we move forward with some of the other medications, we have to be careful with. Disadvantages, it is short term. Unfortunately, none of these things are long term and forever lasting. And it does vary as far as how long. Some of these creams do come with a lidocaine. So lidocaine is an anesthetic or numbing agent, which the lidocaine generally only lasts about an hour or two. So sometimes you get the effect of the lidocaine to numb the skin, and to help out with the pain there. And as I alluded to before, they're not actually getting to the root cause. That doesn't necessarily mean that it wouldn't help, but there's no effect on inflammation, which again, as I've said multiple times, but can be a big cause of the pain. So that's something to keep in mind as we consider this as a medication. The next one will be topical anti-inflammatories. So the main topical anti-inflammatory is diclofenac, or Voltaren, which most of you may have heard of. It comes in most commonly in 1% formulation. It is now over the counter for the past about year. It has become over the counter, and that is the same dosage as the one that was prescribed previously. And so the dosage for us is about 2 grams, and it does come with a measuring stick, which 2 grams comes out to about a pea size. So you would take that pea size and rub it to the affected area up to 4 times a day. Now, there is approval mainly just for the knee. In saying that, there is off-label use that I do recommend patients for this use on like any other joints, so hands, shoulders, those sort of things like that. And kind of both of these, the topical medications, in my opinion, they do work a little bit better with some of the smaller joints. even knees, but hands, feet, versus some of the larger joints and deeper joints like a hip or shoulder. So the advantage of this is an anti-inflammatory, so it does decrease inflammation. That is getting to one of the root causes of pain. So if we can get to the root causes of pain, then obviously that will help with our pain and be beneficial with the medication. There is little systemic effect with these, so it's not to the degree of some of the oral medications, oral anti-inflammatories, which we'll touch on. But there is some effect through the rest of the body. So it's always good to talk over with your healthcare provider, again, whether it's a primary care or orthopedic physician. And because there's a little systemic effect, less side effects. Some of the more common side effects can be a little bit of irritation of the skin at times. You want to be careful with any of these that after applying it, you want to wash your hands, and make sure you don't get it into your any eyes or mouth with this. And then the disadvantages is that it is up to 4 times a day. And a lot of patients do need to use it, for those 4 times a day. I do have some patients that, to help with that at nighttime. So they'll kind of rub it on at nighttime to help them with sleep and kind of gets them through the night. So the next group that we'll talk about will be oral medications. So these are broken down into two groups: acetaminophen and NSAIDs. So acetaminophen or Tylenol is a pain reliever. It's not an anti-inflammatory. Technically, what it does it stops in the pain cascade and blocking an enzyme in there. So the dosage it varies a little bit, but 650 milligrams to 1,000 milligrams at a time every 6 hours. The maximum dosage in a day would be 3,000 to 4,000 milligrams, and that varies. For most patients, it would be about 4,000. If there are some liver concerns, then it could be 3,000. And so this dosing is the standard dosing of 325 milligrams. There's the extra strength Tylenol, which would be, or extra strength acetaminophen, which would be 500 milligrams. So again, the varying as far as usually two Tylenol at a time, whether that's the 650 total or 1,000 milligrams. And again, not to go past the 4,000 milligrams. The side effects and concerns with this would be, again, we want to make sure if there are any liver issues and underlying liver problems, then acetaminophen might not be the best choice due to the excretion and the breakdown being through the liver for Tylenol. And just some minor side effects can be some nausea and stomach pain. And then the kind of the most common use or most common oral medication that's used for arthritis is NSAIDs, so non-steroidal anti-inflammatory drugs. So anti-inflammatory, again, stopping the inflammation or decreasing the inflammation. There's a bunch of different ones. So the three main over-the-counter are going to be your aspirin, ibuprofen, and naproxen. So ibuprofen, same thing as Advil, and naproxen is the same thing as Aleve. We have the maximum dosing for those. Again, these should be discussed with your primary care or your orthopedic as far as total dosing, because that can vary for each patient. And then meloxicam is one of the prescription anti-inflammatories. Maximum dosing on those is a 15 milligram. There's other prescription anti-inflammatories, Lodine or Etodolac. There's oral Voltaren. Some of those are a little bit more harsh on the kidney system. So again, that's something that would be discussed with the provider. So what does it actually do? The NSAID actually blocks an enzyme. called cyclooxygenase, which is part of your inflammation cascade. So blocking the enzyme shuts down the inflammation. And as I've alluded to multiple times now, inflammation can be a source of the pain. Therefore, if we block the inflammation, then we would be decreasing the pain. So side effects, interaction with blood thinners is one of the most common things that we see. So if we are on blood thinners, then NSAIDs would not be good because NSAIDs can increase the efficacy of the blood thinner, making the blood even more thin. So especially with Coumadin, where you have to have it monitored, that's where it could be problematic if we're taking NSAIDs while on one of those medications. One of the most common side effects is GI upset, and it can lead to GI ulcers. So it's always recommended with NSAIDs to take it with food to decrease the likelihood of getting upset stomach, heartburn, indigestion, and eventually leading to potentially ulcers. And then there is effects of on blood pressure and kidneys when on long-term use. So it's always advised to have those things monitored every 3 to 6 months if on an NSAID for a long period of time. So advantages and disadvantages. So advantages, anti-inflammatory. Since it is an oral medication, it can affect multiple areas. If we're having arthritis in multiple locations, multiple, both knees and shoulders, that sort of thing like that, this could be a little bit more advantageous as it is a systemic effect through the entire body. Disadvantages are the systemic effects. So like we talked about with the side effects, and needing to monitor blood pressure and kidney function if on it long term, and the fact that it does interact with medications mainly with mainly with the blood thinners. All right, and so the last category that we'll go through is injections. So two main type of injections. The most common one, I'm sure most, if not all of you, have heard of, is corticosteroid or cortisone. And so we'll talk about that, and then we'll also talk about hyaluronic acid or viscosupplementation or gel injections, which I'm sure a lot of you have heard about. So the most common injection that we do is corticosteroid or cortisone. So corticosteroid or cortisone injection, it's a mixture of two things when we inject it into the body part. And that is lidocaine, which again is a anesthetic or a numbing agent, and a steroid. A steroid is an anti-inflammatory. So the anti-inflammatory combined with the lidocaine localized into the joint to try to help with the symptoms of arthritis. So the side effects, what are some of the common side effects? So we have to be careful with cortisone injections with diabetics. Reason for that is it is a temporary increase, but there is an increase in blood sugars. And so those increases in blood sugars can be definitely detrimental at times. So I always have a discussion with the patient that it's a diabetic, depending on their last hemoglobin A1C. We have that discussion if cortisone is the right treatment for you. There is no set cutoff for hemoglobin A1C, and so it does vary on provider. It does vary on how things have been over the last several months, maybe last couple of years. If it's kind of waxing and waning as far as sugars go, then I'd be less likely rather than a person that's been controlled and maybe had a little issue the last couple months, that sort of thing like that. It can cause soreness after an injection. So I always recommend after an injection, taking it easy. Doesn't mean you have to be like bed rest after a cortisone injection, but it's always a good idea to take it easy for a good 24, 48 hours. Ice if you need to, that sort of thing like that. And then on less common occasion, by about less than 1% of the time. We do see some flushing where the cortisone can cause, the steroid aspect can cause a very warm and kind of heavy feeling in kind of the face, and that usually subsides after 2 to 3 days at the most. But that can be a side effect of a cortisone injection. So most common question that we get when we talk about cortisone in the office is how long? How long is this going to last? And that's the $1 million question I always say to everybody. And that varies for every single person. If you look at studies, unfortunately, studies show that effectiveness can be on average about 2 weeks. Now, anecdotally, I think that's off a little bit, but it does vary. I have plenty of patients that unfortunately don't get relief or get relief from the lidocaine, being maybe a couple days. And I've had patients that get relief for a year, 2 years, and everywhere in between. So it does vary for everybody. And there's no correlation of if you have this much arthritis that we see on x-ray or imaging, that you'll get this much relief. It ultimately does vary on every patient. How often can you get cortisone? Into the same joint, we would not want to do it earlier than every 3 to 4 months. The reason for that is, unfortunately, cortisone, more times you do it, can be detrimental to the joint. So it actually can do the opposite effect and actually break down the joint a little bit quicker. And how many in your lifetime? There is no set number. I know there's, some people will say, well, can you only have 3 in your lifetime, 5 in your lifetime? Honestly, there is no set number of cortisone injections into the same body part. Excuse me. It ultimately comes down to how are they helping, when you're doing sequential ones, repetitive ones. Are they still helping? How long are they helping? And so that's the discussion to have when we're talking about cortisone. Um, and so that's why there is no set number for that. And so usually the discussion that I usually have is, if we do a cortisone and it lasts for 6 months, 8 months, then obviously we can repeat it in that time frame. Now, if we do a cortisone and it only lasts a couple weeks or a month, recommendation is not to do another cortisone injection, especially if it's within the 3 to 4 month time frame. Then we need to start thinking about some of the other treatments for arthritis, and whether that's bracing therapy, and then end all be all being joint replacements. And generally, more cortisone that you do generally gives us less and less effect over time. So a lot of times the first cortisone can be very, very beneficial and may last 6, 8 months. Sometimes the second one can last just as long. Usually does not last longer, but sometimes that second one may only last 3, 4 months. And so you might get that decrease. Sometimes it's a slow decline in efficacy, but sometimes it is a steeper decline. So advantages and disadvantages. Advantages, it is localized. So there is a small systemic effect with the steroid part, and that's why, excuse me, and that's why we have to be careful with diabetics, um, specifically uncontrolled diabetics, because the cortisone does affect the blood sugars. You generally do get quicker relief with this, and I put in quotes stronger. It does have a little bit of a stronger anti-inflammatory effect than some of your over-the-counter. And my belief is that it is the fact that we're localizing it to that joint. And disadvantages, the blood sugars and repetitive cortisone, repetitive cortisone injections can be more detrimental to the joint itself than good for the joint. And so again, that's why we have that kind of restriction on limiting to every 3 to 4 months at the earliest. So the last thing we'll talk about is hyaluronic acid. So this is lubricant or gel or viscosupplementation injection. It is synthetically made. So it used to be from, I'm sure a lot of you remember, it used to be from rooster combs, but it is no longer from that. It is actually synthetically made. There are multiple different companies that make the different hyaluronic acid injections. So how does hyaluronic acid how does hyaluronic acid injections work? Normal joints have hyaluronic acid. So why is hyaluronic acid important? Well, when we have hyaluronic acid and at the normal concentration and at the normal level, the hyaluronic acid helps lubricate the joint. So it keeps it kind of at a smooth surface, keeps that friction low, but it also has anti-inflammatory component in it. Okay, so when we lose that hyaluronic acid, and that decreases when we do get arthritis. So we lose the amount and we lose the concentration level, which is important for its efficacy. So when we lose that, we're actually losing some anti-inflammatory effects, and again, we're losing some of that friction, or I'm sorry, losing some of the smooth surface, losing some of that lubrication. Hyaluronic acid injections do not create more joint space, and they do not regenerate cartilage. Okay, so we want to kind of clarify that part. And like I said, it does have anti-inflammatory components in it. It is varies from a series of 3 to 5 injections versus a single shot. There's benefits for both. Most of the time, we choose one or the other, mainly because of insurance reasons. So this is something that would have to get insurance approved. These can be repeated. The earliest would be 6 months, and again, mainly for insurance reasons. And FDA is only approved hyaluronic acid or viscosupplementation injections only for the knee. So we can only do them for the knee. They will only approve them for the knees. So the side effects. So one of the beauties of this is that there is no systemic effects. There's very little chance, since that is synthetically made and you normally have hyaluronic acid in your joints. There's very low risk of a interaction or an allergy to this. The main side effect is generally soreness after the injection. Similar to a cortisone, sometimes it could be a little bit more. It is a thicker fluid, so sometimes it could feel very tight for a day, 2 days. So whenever we do these, it was recommended, again, no strenuous activity, no heavy exercise for a good 24, 48 hours after an injection like this. Again, doesn't mean you have to be bed rest, but just take it easy. Normal everyday activity should generally be fine. Ice can help with, after an injection if it is a little sore, that sort of thing like that. So advantages and disadvantages. Again, it's localized to that joint. Little to no systemic effect at all. Potentially longer lasting than a cortisone injection. And I say potentially because, again, it does vary for everybody. But a lot of times I'll have patients that do get, a month or two out of cortisone, and then get 6 to 9 months out of a gel injection. And so if we can give that reprieve for that time frame, then obviously that's better than nothing at all. There is no effect on the joints from a long-term standpoint. So if you repeat hyaluronic acid injections every 6 months and they're effective for that time frame, it doesn't break down the cartilage like cortisone can when you do multiple. Disadvantages, as with everything, nothing's 100%, so not always effective. Can be a little sore, like we talked about post-injection. It does take some time to kick in. Usually, cortisone does kick in very quickly, mainly because of the lidocaine that's involved with it. But usually that's with, cortisone usually kicks in within a couple days or so. A gel or a hyaluronic acid injection can take even 2 weeks or so to kind of kick in. So we'll kind of wrap up here a little bit. Conclusion. So there's many different options and treatments for osteoarthritis, each with their own disadvantages and advantages. And we always tailor each treatment program for each individual. And that involves, things outside of medications too, whether, again, like I alluded to earlier, some physical therapy, a brace, a cane walker, that sort of thing like that, on top of these. So we take all that into account when we're talking about the whole body as a whole person as a whole, going forward with that.